So what I want to talk today about is about, what can we do from psychiatry to protect mental health? And if you think about that, I think from psychiatry we should try to focus on the prevention of mental disorders. I think there's a lot going on in the field of prevention and mental health promotion, but when we talk about what can we do from psychiatry, I think we should try to prevent the onset of mental disorders. And so that's what I will focus on today. Is that possible? Can we do that? So I think it's not just something I think it's a priority that it's recognized by the whole biomedical field. Of course, we were very proud of this viewpoint paper in JAMA, but I think this also indicates that it's not something that is done by a small group of researchers or practitioners. I think it indicates that prevention of depression and other mental disorders is one of the big challenges of the whole biomedical field. What I will do today is I will talk about what is prevention. So I will try to explain a little about what prevention is. I will focus on why prevention is important. Then I will try to answer the question, is it effective? Can we actually prevent the onset of new mental disorders? And I'll give you one example of a prevention trial we did. We did a lot of them, but one of them pretty recently. And if I have time, then I will talk about a new prevention project, what we're currently preparing. So what is prevention? Well, this is from a report from the National Institute of Health. They made an overview of the different types of interventions you can make. And they said, well, everything you do before somebody meets criteria for a mental disorder is prevention. As soon as they meet these criteria, then we talk about treatment, maintenance treatment, etc. So as long as people don't meet criteria, we can talk about prevention. And there are three types. First, you have universal prevention, aimed at people, at the general population or a part of that, regardless of whether they have an increased risk of developing a mental disorder. For example, school programs in high schools, where interventions are given to all students, regardless of whether they have an increased risk, to try to prevent depression or anxiety or other mental health problems. Then we have selective prevention, which is aimed at people who belong to a high-risk group. And we have a lot of them, as you know. People who have lost somebody by death, people who have been abused during their youth, who have divorced, who retire, who get chronic general medical illnesses. So all the interventions aimed at those groups are selective interventions. And then we have indicated interventions aimed at people who have some symptoms but do not meet full criteria for a disorder. And that's where most evidence is. So if you focus on prevention, then it's indicated prevention where most of the evidence is. I want to show you, before I continue, I want to show you that universal prevention is almost impossible to examine. So you must imagine that if you want to reduce the incidence of new cases of mental disorders, the incidence of new cases is usually in the general population very low. So for example, in the Netherlands, the incidence of depression is about 2.5% in 1 year. So of every 100 people in the general population, 2.5 will get a depressive disorder in the next year. If you want to do research showing that you can reduce that incidence from 2.5 to, let's say, 2 or 1.5%, you can imagine that the power is enormous, that you need huge samples to do trials like that. And they simply have not been done, because you have to do a diagnostic interview at baseline, excluding people with a mental disorder, and then look 1 year later how many of them developed a depressive disorder. That's impossible in universal, well, it's not impossible, it's just very expensive. If you look at other fields of medicine, this kind of things are done, despite the fact that they are so expensive. But it's not done in psychiatry. I try to, in this paper, I also calculated how many people you need to include in a trial on eating disorders. And that was about 3 million per arm, which is, of course, not feasible. So universal prevention is not something, when you look really at the incidence of disorders according to diagnostic criteria, that's just not feasible. We cannot examine the effects. Although it may be very effective, school programs, but if you go more into societal impact, like, for example, on housing, or economic measures, they may well have a big impact on mental health, and they may have a big impact on the incidence of mental disorders. But it's impossible to examine them in randomized trials, so we just don't know whether they're effective. Okay, so now I'll focus on the second point. So why is prevention important? And I'll focus mostly on common mental disorders, because these are the disorders with the highest disease burden. And these are the disorders which are, from a public health point of view, are the most important ones. So other psychiatric disorders are very important from an individual perspective, and of course also from a public health perspective. But depression and anxiety are so common, while they're also having this large impact on a personal level, that they always end up in the top 5 of disorders with the highest disease burden, regardless of which country you look at. So the prevalence of depression is huge, and I will go through some of these points in more detail. But the prevalence is very high. The personal suffering from people with depression is very high. And if you combine that, then you have a huge disease burden. And the WHO started with these lists of disorders with the highest disease burden. And in every list since then, since the 1990s, depression and also anxiety disorders are very high on these lists. One specific thing of mental disorders, and that's often forgotten, is that it's also very important from an economic perspective. So, oh no, I will first do this. This is from the Netherlands. It's a bit of an older top 10 of the disorders with the highest disease burden. But what I like to use this because then they also separated this according to age group. And so here you see that anxiety disorders are at the 2nd place, depression at the 4th place, alcohol dependence on the 8th place. But if you separate this for age groups, then you get this. So these are the top 5 disorders with the highest disease burden according to age groups. And what you see then, what you see then is that in children, they are not that important yet from a public health perspective. But from 15 on until about 50 years of age, mental disorders are the most important drivers of the disease burden. And that's the adult working age. And that's why these common mental disorders are such an economic important issue. If you look at other disorders, heart disease, cancers, diabetes, whatever, most of these are getting more prevalent when people get older. But that's not true for mental disorders. So that's why if you look at mental disorders from an economic perspective, they're much, and for the working age, so to say, they're extremely costly, mostly because of the production losses. And this is, for example, in the UK, the reason why they have started investing about 10 years ago much more in mental health care. Yeah, this is just to show again that this is a slide from the WHO, again illustrating why mental disorders are so important from an economic point of view. And why is prevention in children and adolescents so important? Well, we know that most mental disorders have their first onset between 15 and 25. And so if we would be able to prevent the onset of mental disorders in this age group, then it makes sense that that would have the most impact on the chronic course that many mental disorders have. So if we can intervene in this age group and prevent or delay the onset, then the impact will be as large as possible. And we know also that many of the disorders, when they first appear between 15 and 25, that many of the causal factors go back to childhood. So that is why I think prevention in children and adolescents is even more important than in other age groups. That doesn't mean that all the research has been done in this age group. So I want to show you something else, why prevention is important. So this is from the group of Gavin Andrews from Sydney. It's a bit older now. I don't think it has changed very much. It's also Australian data, but again, I don't think that differs very much from data in Europe. What you see here, what they did is they made an estimate of how much of the disease burden we can take away with current treatments for mental disorders. So what you see is that, for example, for depression, only 16% of the current disease burden can be taken away with current treatments. That's in part because people don't get evidence-based treatments. So suppose that everybody who gets treatment would get an evidence-based treatment, then we would still have only 23% of depression, 23% of the disease burden that would be taken away with our treatments. But we also know that many people don't get treatment at all. So suppose that we would be able to treat everybody who meets criteria for a disorder with an evidence-based treatment. And then this is what you get. Then still only 1/3 of the disease burden of major depression could be taken away with the treatments we have. So about 2/3 of the disease burden of depression and 60% of the disease burden across the most important mental disorders cannot be taken away with the treatments we have. I think that's a very important reason to focus more on depression. Is that really not something we can do to other things we can do except treatment to take away part of the disease burden, which is not taken away by treatments? I think there is. Yes, I'll skip this. Yeah, so I'll skip this too because I already explained why I think that indicated prevention is the most promising. There is quite some research in children and adolescents on universal programs, usually school programs, and they do find effects on symptoms. But these are unselected adolescents, and the effect sizes are pretty small, 0.20, 0.21, I think, yes. Which you could say, well, the impact is large because you reach large samples of adolescents, and then the effect on an individual may be small, but because you reach those large groups, the impact may be large. But I never trust effect sizes which are this small. I always think, well, there should be could be one source of bias and the effect disappears when the effect size is so small. And so I'm not very much enthusiastic about these effect sizes. And furthermore, from a psychiatry point of view, we are much more interested in the incidence of mental disorders, because we focus on disorders. And then you get a different picture. I will skip this because of time. I already talked about the costs. In Holland we have those epidemiological studies. You have them probably in Italy too, where you do these large population-based studies in the general population, random samples, so regardless of whether people get treatment or not, and then you can see how many people meet criteria for mental disorders. And you can then also examine the economic costs of that. And so what we found is that the total cost per million adults of depression is about 600 million euros. So if we could only use a fraction of that money to spend on prevention of depression, I think it would be pretty soon cost effective. So summarizing, why is prevention important? Because of the high prevalence of mental disorders, especially the common mental disorders. The incidence is very high. I didn't talk about that, but if you ask people whether this was the first time they got a depression, in the case of depression, then about 50% of these people say it's the first time they had it. That's probably an overestimation because people tend to forget that they had a depression in the past. But still, even if it would be only 25%, then still the incidence is very high. And what we're doing in mental health care is just wait until these people come to us and then we treat them. And we do nothing while we know that these huge numbers of incidence cases come every year and again. And we hardly do anything to try to stop this influx of new cases. I think we can do better. Wait, I go too quickly. So the costs are very high. The burden of disease is very high. And we have to acknowledge that our treatments are good, but not good enough. And we can only take away part of the disease burden of mental disorders. So I think there is a place for prevention of mental disorders, especially in young people, but I also think across all age groups. But the question is, can we do that? Can we prevent the onset of mental disorders? So if you look at research, there is quite a lot of research on prevention. Hundreds of studies saying they are doing research on preventive interventions at schools, on drug abuse, in nursing homes, at the work site. But from my perspective, we should focus on the incidence of mental disorders. So what we did, and in this case we looked at prevention of depression, is that we only selected studies in a meta-analysis. We've done that a few times. We have done these meta-analyses a few times now. That we only select those studies in which people had a diagnostic criteria at baseline, and people who had a disorder were excluded. And only those who did not meet criteria for a mental disorder or a depressive disorder were included. And then after 1 year or 6 months or 2 years, they were interviewed again with a diagnostic interview to look at the incidence of new cases. And they were all randomized trials where people either got a preventive intervention or usual care. So they got basically nothing. So then you can compare the incidence rates in the prevention group and the control group. So this is what we found in our last meta-analysis that we had, but that's from 2014. We're updating it now. And we had 32 trials then. We will probably have about 40 or maybe 45 trials now. And they were very diverse, so you have to be very careful with what you do. Only 2 universal studies. I explained you why, because they are so extremely expensive and always underpowered. But we had quite a few selective studies, indicated prevention studies, quite a lot on students and adolescents, so that's good. We can say something about that. But also in all kinds of other groups, pregnant women, people in general practice, people who have general medical disorders and were screened at hospitals. So all kinds of interventions. Mostly what happens in these studies is that psychological treatments which are used in treatments are translated into preventive interventions. So they're made simple, made easier, not so intensive, that kind of thing. Most are based on cognitive behavior therapy, but also on interpersonal psychotherapy. So this is what we found. We found for indicated prevention an incidence rate ratio of 0.74, which means that the risk of developing a depressive disorder was 26% lower than in the control group. So if you get an intervention like this, the chance of developing a depressive disorder is significantly smaller than when you don't get the intervention. We found a comparable incidence rate ratio for selective intervention, but that included 1, so that was not significant. So we really don't know yet whether indicated prevention is effective or not. And we found no evidence for universal prevention. Of course, this is all these studies have a limited follow-up time. So you never know whether you actually prevented the onset of the disorder or that you just delayed it. We simply don't know. But from a public health perspective, and especially when you look at young people, then even delaying has a big, can have a big impact from a public health perspective. We did not find any difference between adolescents or other age groups or other target groups. So this seemed to be all effective. Let's see. So I will try to give you an example of one trial. We did several of them. I started with these trials 20 years ago. But this is, we were very happy because it was published in JAMA. But it's also a very good example of how these trials look like. So what we did is we selected people with subthreshold depression through the internet in Germany. We did this with a German group. And so we recruited people through the internet, did a diagnostic interview with them, and those who scored high on a depression scale but did not meet criteria for a major depressive disorder, they were included. And they either got the preventive intervention or nothing, care as usual. And so and then we could look at follow-up whether they developed a depressive disorder. And the people in the prevention group, they got a web-based intervention, so a psychological treatment consisting of problem-solving therapy and behavioral activation. Very simple, very straightforward, not complicated. And what we found is, so we randomized 406 participants, and we found that the incidence of major depression was 27% in the prevention group compared with 41% in the control group, which indicates a hazard ratio of 0.59 and the numbers needed to be treated of 6, which is pretty good for this kind of intervention. These numbers needed to be treated are not very different from what you find in treatment studies, whether these are pharmacological or psychological. So I want to finish. I have a few minutes more, don't I? I want to finish with another project of which I am very enthusiastic. And I think this is going to be one of the big new prevention trials across the world, because it's not something only we are doing. But the idea is that we know that college students, and especially medical students, often have a lot of mental health problems. So what we try to do now is this large new project, which consists, I'm going too quickly. Yes, so it's not just something that happens in Holland, it's an international project. It consists of an epidemiological part, so all students get a survey on mental health problems. That part is coordinated by Ron Kessler at Harvard. He is leading the World Mental Health Surveys, and this college student survey is another branch on that bigger project. And these are the countries that are now participating, and there are all kinds of countries joining the whole initiative. We now have 25,000 students who have filled in the questionnaire, and we follow them up through time. So it's increasing pretty quickly. But what we also do is, if these students score high on depression or anxiety at this moment, that's the trial that is running now. If they score high on depression and anxiety, then they get an internet-based intervention. And so of course, it's a randomized trial. And the idea is that if that intervention is effective, we can deliver it through the survey next year as part of routine care, so to say. Then we don't have to do a trial, because we know it works, and then you can implement it automatically. And so it's, in a way, this is an integration of epidemiological, clinical, and implementation research at once. The focus is on early intervention and prevention. And, well, this is just to show the intervention we use. It's the eye care intervention developed within another large European project. And it's basically CBT, which we deliver through the internet. And we use trained psychology students to coach the students who go through the intervention. We've done that in many trials before, and we know that that is effective. Yeah, this is just the intervention again. But the interesting part, and that's what we're developing, so the idea is that universities who participate, they can develop their own interventions. So if we develop something about worrying or generalized anxiety, it can be used, and we show that it's effective, it can be used next year in a university in Hong Kong, or the other way around. And so each university decides what the priorities are to focus on what these students want and what they want in their university. And if it's available and if it's evidence-based, it becomes automatically available for all the other participating universities. So what we try to do is we focus on all kinds of general psychological problems of students. And we ask them in our survey, what problems do you have? We ask them to rate whether they have all kinds of problems, like procrastination, not doing what you should do. That's something that, so about 67% of all students say they don't do what they should do. They procrastinate. And those people are also the ones who score high on depression. And we think that they don't want to participate in interventions for depression, but if we say we're going to learn them how to cope with procrastination, that's what they will do. And in the same way they have problems with perfectionism, things like test anxiety, low self-esteem. And we think that if we focus on problems like that, that could be another way of preventing the onset of mental disorders. But this is all work in progress, but it's really one thing I'm very enthusiastic about. So I wanted to share that with you. Okay, I come to my conclusion. The public health challenge of depression and other mental disorders is huge. I think it's recognized across the world now. I was last week in London, where 60 ministers of health across the world came together to prioritize mental health and see where they can work together to do something about mental health. The Secretary General of the United Nations has personally indicated mental health as a priority for his period that he's doing this work. So there is a momentum for mental health. And I think prevention is certainly one of these issues where we should, as researchers, but I think we should also think about how can we apply these things in routine practice. There is a global consortium for prevention of depression, which I coordinate. So if you're interested, just send me an email or talk to me after my presentation. The next meeting is next week in Mallorca, and next year we'll go to the US again. And I want to thank you for your attention and for not falling asleep.